Good day to everyone. I will be talking on the topic developmental pharmacology, which will deal mainly on drug therapy in infants and children. It is important to consider the fact that infants are not small children and children are not small adults. Since physiological processes are different in neonates and young children as compared to adults, and this may influence the PK and PD variables in infants, and it changes over time from childhood to adulthood. At the end of the lecture, the student should be able to explain the developmental changes in pharmacokinetics and pharmacodynamics, cite examples of maturational changes effect on representative drugs, and familiarize with drugs used during lactation. This would be the outline of my talk. First, let's discuss drug absorption. What are the factors influencing drug absorption? Intravenously administered drugs are completely available to the systemic circulation. It is the drugs given subcutaneously, intramuscularly, inhalationally, and orally whose absorption may be influenced by the blood flow at the site of absorption, gastrointestinal function, and age after birth. So how does blood flow affect absorption? More drug targets receptors more rapidly in vessel-rich organ groups like the brain, kidney, and liver. Hence, physiological conditions that may reduce blood flow to these areas may affect absorption, as seen in cardiovascular shock, vasoconstriction due to sympathomimetic agents, and heart failure. One good example is a sick, premature infant requiring intramuscular injections. Aside from little muscle mass with diminished peripheral perfusion to the muscle area, there can be irregularities in absorption by the intramuscular route. The drug levels may be difficult to predict. Absorption is low with shock, and when perfusion improves, there can be sudden increase in the drug levels, leading to potential toxic concentrations of the drug, and examples of which may have toxic levels would be cardiac glycosides, aminoglycosides, and anticonvulsants. There is greater skin to BSA ratio in the transdermal route, approximately 3 times that of adults. Examples are hexachlorophene, used before for bathing infants, which causes neurotoxicity. Povidone iodine topical disinfectant can cause neonatal thyroid dysfunction. Hydrocortisone cream for diaper rash can cause HPA suppression, and 4% lidocaine can cause heart effects. As for the rectal route, it is useful. Drugs are well absorbed, however, rectal inability to retain suppository for the duration of time needed to achieve optimal absorption due to strong rectal contractility can reduce absorption. The physiological parameters that affect gastrointestinal function, specifically in the neonates, are gastric pH, gastric emptying time, peristalsis, and GI enzymes. Gastric pH is important for drug stability, dissolution, and ionization, all of which have an impact on absorption. In full-term infants, gastric acid secretion begins soon after birth and increases gradually over several hours. Gastric pH is neutral 1 to 3 days after birth, probably because there is amniotic fluid in the stomach. Then this is followed by an acidic pH. In premature infants, gastric acid secretion is more slow, with highest concentration on the 4th day of life. And if a premature infant is on continuous milk feedings, gastric pH tend to be higher. What would be its effect? Higher gastric pH will cause reduced absorption of weak acids such as phenytoin because of increased ionization, as well as reduced absorption of weak bases such as ketoconazole because of decreased solubility. Gastric emptying time is prolonged in full-term infants up to 6 to 8 hours in the first days after delivery. And what would be its effect? Drug absorption in stomach would be complete, and if absorbed in small intestine, therapeutic effect would be delayed. Neonates have irregular and slow peristalsis, making it unpredictable. If slow peristalsis, more than usual amount is absorbed, which can lead to toxicity, and if fast like in diarrhea, then extent of absorption is decreased. The gastrointestinal enzymes in full-term infants are low, specifically alpha amylase and pancreatic enzymes, up until 4 months of age, and hence there is poor breakdown of carbohydrates, fats, and protein. There is immature hepatic and intestinal UGT2B7 enzymes, which is the explanation for occurrence of gray baby syndrome with use of chloramphenicol. Neonates also have low concentrations of bile acids and lipase, implying low absorption of lipid-soluble drugs. This table shows the oral absorption of various drugs in neonates as compared to older children and adults. There is increased absorption of ampicillin and penicillin G, decreased absorption of acetaminophen, phenobarbital, and phenytoin, and normal for diazepam, digoxin, and sulfonamides. Now we discuss drug distribution. Several factors affect drug distribution in neonates and infants, namely total body water, fat content, protein binding, and membrane permeability, as well as larger potential compartment. The percent total body water in neonates is 70 to 75%, preterm 85%, infants 60 to 65%, as compared to adults, which is 50 to 60%. For extracellular water, it is 40% of body weight for neonates and infants, and 20% body weight for adults. What does this imply? Larger total body water and extracellular water space in neonates and infants lower the plasma concentration of the drug that distributes into this compartment. There is much greater distribution of highly water-soluble drugs like your aminoglycosides, amikacin, linezolid, and paracetamol. There is reduced accumulation for highly lipid-soluble drugs like amphotericin, diazepam, benzodiazepine, digoxin, and amiodarone. In the premature baby, the total body fat is only 1% of total body weight, in contrast to 15% body weight in full-term infants and 20 to 25% in a 1-year-old child. This has implication on organs that generally accumulate high concentrations of lipid-soluble drugs. So lipid-soluble drugs may accumulate in smaller amounts in premature infants. As to plasma proteins, neonates and young infants have lower concentrations of most relevant plasma-binding proteins like albumin, alpha-1 acid glycoprotein, or plasma globulins. The amount and type of circulating plasma proteins will not only influence drug disposition but also drug action, because only unbound or free drug can be distributed throughout the body and exert a pharmacological effect. However, there can also be competitive binding with endogenous compounds like bilirubin and free fatty acid that can also increase the free drug. Drugs that may be affected by protein binding are opioids, amide local anesthetics, and muscle relaxants, since they bind to albumin and alpha-1 glycoprotein. The unbound or free drug is available to cross biological membranes, bind to receptors, and achieve a therapeutic concentration. Hence, lower concentrations of albumin and alpha-1 acid glycoprotein result in more unbound drug availability to target receptors. Thus, with reduced protein binding, there's increased free concentration and free fraction of the drug, enhancing capacity of the active drug to diffuse more easily to other compartments that results in more interaction with receptors. To strike balance, there will also be an increase in the clearance rate of the drug. This principle must be factored in when prescribing a drug like theophylline for apnea of prematurity. The target concentrations will be lower, accounting for less protein binding and hence greater free drug concentration in the neonate. Please remember, the influence of protein binding on free plasma drug concentration is limited to drugs that have a moderate to high degree of protein binding, and a narrow therapeutic index, exemplified by phenytoin and etoposide. This is because even a minor difference in protein binding will result in a significant difference in the free concentration of the administered drug. Protein binding is generally reduced in the neonates, especially with local anesthetic agents, diazepam, phenytoin, ampicillin, and phenobarbital. So the free or unbound drug is increased. Because the free drug exerts the pharmacologic effect, this can result in greater drug toxicity despite normal or even low plasma concentration of total drug. Let's take diazepam as an example. If the total drug in plasma is 300 micrograms per liter, if the drug is 98% protein bound in an older child, then there is 6 microgram per liter as the concentration of the free drug that produces the desired effect without toxicity. However, if given to a preterm in a dosage adjusted for body weight, if with protein binding of only 90%, then drug concentration will be 30 micrograms per liter or 5 times higher than the older child, although there is higher free concentration that may result in faster elimination. The initial concentration may be quite toxic at the start. Some other drugs may also compete with serum bilirubin for binding to albumin, causing substantial amounts of bilirubin to enter blood-brain barrier, causing kernicterus, exemplified by sulfonamide in preterm infants. On the other hand, in patients with increasing bilirubin levels like in physiologic jaundice, the bilirubin can displace a drug from albumin binding, leading to increased free drug concentration, causing greater therapeutic effect of toxicity, exemplified by phenytoin. How about membrane permeability? Drug distribution to deep compartments such as the central nervous system is delayed and limited due to functional endothelial tight junctions in combination with low efflux transporters during the embryonic and neonatal stage. As the baby matures, there is progressive increase in efflux transporters like P-glycoprotein expression and function, as well as tight junction capacity, where there seems to have a higher passive diffusion in early infancy. In neonates, there is larger potential compartment of brain. In infants, the brain is around 10 to 12% of weight as compared to 2% of weight in adults. What does this imply? There is risk for drug-induced neurotoxicity for infants and neonates. Here are some disease-related differences in drug distribution. In obese patients, there is a higher fat mass, mainly altering the distribution of lipophilic drugs. In protein malnutrition, it affects absorption and clearance to a larger extent, but does not extensively affect distribution volume for most compounds. In patients with patent ductus arteriosus and sepsis, there is further increase in the distribution volume in preterm neonates, and this is most pronounced for water-soluble compounds. In patients with nephrotic syndrome where hypoalbuminemia is present, obviously there is less protein binding and hence increased levels of unbound drugs that can act in the receptors. For environmental aspects, competitive binding is a major issue in the neonates with hyperbilirubinemia because of the displacement of initially bound bilirubin that may result in kernicterus, and this is seen with the drug ceftriaxone. So we don't use ceftriaxone in neonates because of its ability to displace bound bilirubin, which will cause kernicterus in the baby. As to binding characteristics, alpha-1 acid glycoprotein will increase after surgery, resulting in a somewhat higher binding capacity for local anesthetics. Meningitis is associated with inflammation, and this will result in less effective tight junctions. A similar pattern is also seen in the setting of severe traumatic brain injury. For ECMO or extracorporeal membrane oxygenation, its effect is on drug disposition because of the additional external volume because of the membrane and tubing volumes, as well as the lower plasma protein and associated fluid retention that are commonly observed. Let's move on to drug metabolism. The metabolism of the majority of drugs occurs in the liver, and a minor proportion occurring in other organs such as the kidneys, lungs, blood cells with esterase function, placenta, and brain. The CYP system is immature at birth and does not reach adult functionality until the first or second month. This immaturity may explain the prolonged clearance or elimination of some drugs in the first few days to weeks of life, as well as the inability of the liver to convert a precursor into its active form. But the CYP450 system can be induced by a variety of drugs like your phenobarbital. It is the age from birth, not gestational age, that determines how premature or full-term infants metabolize drugs. The CYP3A subfamily covers your CYP3A4, 3A5, and 3A7 with completely different age-related activity patterns. CYP3A7 has a high activity during fetal and early infancy with subsequent decrease for hepatic but not for bronchial mucosal tissue. In contrast to your CYP3A4, 3A5, which matures slowly and only reaches an adult level of activity at the end of infancy. The most extensively evaluated in vitro CYP3A compound is midazolam. How does drug metabolism compare in neonates versus childhood? So in neonates, there is substantially lower drug metabolizing activities of your cytochrome P450 superfamily and conjugating enzymes, around 50 to 70% of adult values. Second, there is glucuronide formation reaching adult values between 3rd and 4th years of life. Many drugs have slow clearance rates and prolonged elimination half-lives in early life. So what would be its effect? So the immaturity predisposes the neonate to adverse effects from drugs that are metabolized by the liver. Hence, drug doses and dosing schedules should be altered appropriately. And consider also if the mother is taking any drugs that can induce maturation of fetal hepatic enzymes like phenobarbital. In childhood, from toddlerhood, this is 12 to 36 months, the metabolic rate of many drugs exceed adult values. Hence, this often necessitates larger doses per kilo than in later life. Here are some of the drug metabolism effects and their mechanisms. With chloramphenicol exposure of neonates, the adverse effect is gray baby syndrome, which may relate to normal dosing in the presence of impaired glucuronidation. Use of valproic acid can cause hepatotoxicity in infants and children, and this relates to differences in the capacity of your specific DMEs, your CYP2A6, and different UGTs. For ifosfamide, it can cause renal tubular toxicity, explained by differences in the ontogeny of specific DMEs, your CYP3A4 versus your CYP2B6 in the kidneys. Okay, let's move on to drug excretion. The elimination of drugs by the kidneys is dependent on 3 processes, namely glomerular filtration, tubular excretion, and tubular reabsorption. Glomerular filtration is responsible for the elimination of a larger number of water-soluble drugs and drug metabolites. Excretion may be reduced compared with older children and adults because glomerular filtration and tubular renal function are reduced in the newborn. Let us look at this illustration. In the y-axis is the percent excretion in the adults, and in the x-axis, we have the postnatal age in weeks. We can see here that glomerular function has increased to 50% of the adult value by 3rd week of life, and by 12 months, the GFR is predicted to be 90% of the adult value. Therefore, drugs that depend on renal function for elimination are cleared from the body very slowly in the first weeks of life. As to tubular function, the tubular secretory and reabsorptive capacity appear to mature at slower rates. Tubular secretion is reduced at birth to approximately 20 to 30% of adult capacity but matures by 15 months of age. Tubular reabsorption is the last renal function to mature and does not reach adult levels until 2 years of age. This delay in the development of tubular functions may have variable effects on the clearance of some drugs, for which tubular secretion or reabsorption is important. An example is digoxin, which undergoes some active secretion and therefore with lower clearance in neonates. Drugs that depend on renal function for elimination are cleared from the body very slowly in the first weeks of life. Examples are penicillin and ampicillin. And there is also observed decreased rate of renal elimination in neonates for aminoglycosides and digoxin. Dosing is usually guided by determination of drug levels, and therefore blood level determination is necessary at intervals throughout the course of therapy for dose adjustment. For toddlers, they may have shorter elimination half-lives of drugs than older children and adults due to increased renal elimination and metabolism. Hence, the dose per kilo of digoxin is much higher in toddlers than adults. Adolescence is not simply a link between childhood and adulthood. There are also observed pharmacokinetic changes in puberty due to physiologic changes, examples of which are hormonal fluctuations in sexual maturation that can alter the efficacy and toxicity of many drugs, increase in body fat which can alter drug distribution. A good example is for the drug lopinavir. It has age and sex-related differences in drug clearance. There is unobserved no difference between prepubertal boys and girls, but after age 12, drug clearance in boys is 37% greater than girls due to reduction in CYP3A4. Other physiologic changes would be increase in serum proteins that can alter binding characteristics of drugs. Renal function as measured by GFR may exceed average adult values, resulting to rapid clearance of renally eliminated drugs like aminoglycosides and vancomycin. Observed metabolic changes which cause reduction in drug clearance with advancing sexual activity, suggesting reduction in UGT2B7. Example would be for caffeine metabolism via CYP1A2. It appears to decrease earlier in puberty for girls than boys, showing slowing down of N-demethylation in girls. Now we move on to pharmacodynamics, where significant differences in response of common therapies in neonates and infants are observed. This is due to maturational changes in receptor conformation, density, and affinity, as well as signal transduction that can result in clinically significant differences in responses to common therapies. Pharmacodynamics may be affected by organ function and pharmacogenetics. Pharmacodynamics are affected in a substantial way by anesthetic and critical care interventions. Example, if a patient is on positive pressure ventilation, this may be associated with reduced clearance, and this is attributable to the reduced hepatic blood flow with a drug that has perfusion-limited clearance. As to pharmacogenetics, it is also a determinant of drug action in the developing child. Example, if there's absence of receptors. In addition, there appears to be an enhanced sensitivity to drug response that is associated with development, and that is not produced solely by age-associated changes in drug disposition. Example would be altered concentration versus effect profile for cyclosporine in young infants, and a higher sensitivity toward QTc prolongation in neonates as compared to older children. Another thing is that neonates are sensitive to the central depressant effects of opioids than are older children and adults. Example would be codeine absorbed through breast milk, and they are noted to be more sensitive to the central nervous depressant effects of morphine. It is commonly assumed that attainment of a systemic drug exposure in an infant or child is comparable to that observed in adults, that it will produce an identical action in the pediatric patient. In some cases, this is not true. Examples of pharmacodynamic responses would be higher incidence of valproic acid-associated hepatotoxicity in young infants as compared to adults, greater frequency of paradoxical central nervous system reactions to diphenhydramine in infants. There is higher incidence of weight gain associated with use of atypical antipsychotic agents in adolescents, and there is altered concentration versus effect profiles for warfarin in children with congenital heart disease. Thus, developmental changes in PD must be considered to have their own dimension. Other examples of pharmacodynamic response would be for drug dopamine. Infants are relatively resistant to the effects of beta-adrenergic agonists like dopamine due to a reduction in adrenergic receptor activity or a downregulation of receptors within the myocardium of preterm and critically ill patients. Thus, they are in need of higher dopamine infusion rate at 40 micrograms per kilo per minute. During childhood, there is also a different drug adverse effect profile. They have higher incidence of serious dermatologic reaction. Example would be for drug lamotrigine. It causes toxic epidermal necrolysis, which is dose-related toxicity, probably due to limited glucuronidation to inactive metabolites. As to dosing, there is a rather ironic requirement for a larger initial drug dose in infants and small children in order to achieve target concentration, and this is especially seen in anesthetic agents. This may be explained by enhanced clearance and a larger central compartment volumes in infants and small children, resulting to reduced blood concentrations compared with adults. What are the pitfalls of pediatric dosing? Many pediatric doses are calculated using body weight, and major dosing errors result from incorrect calculations. This error can be tenfold due to incorrect placement of decimal points. And the drugs highly prone to errors are those with narrow therapeutic window, like digoxin, insulin, and potassium. An error in the placement of decimal point may lead to toxicity and death. Hence, we use a leading zero plus decimal point and avoid using zero after a decimal point. Another pitfall is the dosing form of the drugs. Many pediatric drugs are in the form of elixirs and suspension. Drug molecules in elixirs are dissolved and evenly distributed, hence no shaking is required, unlike the suspension, which contain undissolved particles that must be distributed throughout the vehicle by shaking. If not shaken, there may be less plasma concentration of the drug in the early course of therapy and toxicity towards the end of therapy. Hence, the prescriber should know the form in which the drug will be dispensed and provide proper instructions. Adherence is another important thing to establish. Practical and convenient dosage forms and dosing schedules should be chosen. This is particularly true with antibiotics, where the duration is usually not completed since they have seen improvement of symptoms already in the patient. The pediatric dose approximation can be made by several methods based on age, weight, or surface area. Age and weight are conservative and tend to underestimate the required dose. Surface area is more likely to be adequate. It has to be remembered that when calculating based on weight, the calculated pediatric dose should never exceed the adult dose, or transition to adult dosing whenever the calculated weight-based dose exceeds the usual adult dose. When there is no specific dose range recommendation per kilo, then we can estimate the pediatric dose using the Young's rule. The dose is equal to adult dose times age in years over age plus 12. Or we can estimate the pediatric dose based on weight through Clark's rule, where the pediatric dose is equal to adult dose times weight in kilograms over 70 or adult dose times weight in pounds divided by 150. Here we can see in the table the weight in kilograms and pounds with the approximate ages and the surface area with the recommended percent adult dose dosage for the BSA. How about drug use during lactation? Most drugs administered to lactating women are detectable in breast milk, but the concentration of drugs achieved in breast milk is usually low. As for the timing of intake of drugs for mothers, the drug should be optimally taken 30 to 60 minutes after nursing and 3 to 4 hours before the next feeding. This allows time for drugs to be partially cleared from the mother's blood, and the concentration in breast milk will be relatively low. As for the drugs with significant concentrations detected in breast milk, they are tetracycline, isoniazid, barbiturates, chloral hydrate, diazepam, opioids like heroin, methadone, morphine, alcohol, lithium, and radioactive iodine. Breastfeeding is contraindicated in mothers receiving chemotherapy or those receiving cytotoxic or immunomodulating agents. Nicotine and coffee levels are low in breast milk. The following tables will show the possible side effects of drugs in lactating babies. For caffeine, if taken in moderation, it is safe because concentration in breast milk is low. For chloral hydrate, it may cause drowsiness if infant is fed at peak concentration in milk. For chloramphenicol, the concentration is too low to cause gray baby syndrome, but the possibility of bone marrow suppression does exist. So the recommendation is not to take chloramphenicol while breastfeeding. For codeine, it has variable effects based on genetic polymorphisms. It is safe in most cases, and the neonatal toxicity described when the mother is ultra-rapid 2D6 metabolizer, producing substantially more morphine from codeine. For ethanol, it has moderate effect, hence moderate ingestion by mother is unlikely to produce effects in infant. Large amounts consumed by mother can produce alcohol effects in infants. For heroin, it is also significant since it enters breast milk and can prolong neonatal opioid dependence. Radioactive iodine enters milk in quantities sufficient to cause thyroid suppression in infant. Isoniazid has milk concentrations equal to maternal plasma concentrations, and therefore a possibility of pyridoxine deficiency may develop. Lithium is variable. In some cases, large amounts enter breast milk. Methadone has significant effect, but it can be continued in breastfeeding under close physician supervision. Signs of opioid withdrawal in the infant may occur if mother stops taking methadone or stops breastfeeding abruptly. For oral contraceptives, it may suppress lactation in high doses. For phenobarbital, hypnotic doses can cause sedation in the infant. For prednisone, if with low maternal doses like 5 mg per day, it is safe. But doses 2 or more times the physiologic amounts like more than 15 mg per day, it should be avoided. For radioactive nuclides, the baby will be exposed to radioactivity, so we need to ensure that the mother has cleared the radioactive nuclide before feeding. Tetracycline has moderate effect since there's a possibility of permanent staining of developing teeth in the infant, and so should be avoided during lactation. Theophylline has moderate effect and it can enter breast milk in moderate quantities but not likely to produce significant effects. In summary, we have discussed the key differences in pharmacokinetic effects between children and adults with its implications. We have discussed the factors affecting drug absorption, gastrointestinal function, and distribution of drugs. Different diseases can affect distribution. Drug metabolizing activity is lower in neonates and drug elimination is decreased. Additionally, the pharmacodynamic maturational changes may affect response of body to drugs as to its therapeutic effect, subtherapeutic effect, side effect, or toxic effect. Dosing is affected by dosage forms, accuracy of dosage calculation, and adherence. Most drugs are detected in breast milk, but usually in low levels. These are the references used for this lecture. Thank you for your attention.